Good morning, everybody. Today we have a really great presenter who's been with us before, Dr. Sarah Rudman, who's going to be giving us a lot of great updates about the Santa Clara County response to the pandemic, as well as other information to help us better understand what's going on in our county. Dr. Pinsky, moving on to focus on variants.
Thank you, Errol. Good morning, everyone. Share my screen. So our variant update, the variants are very stable. Like the rest of the United States, the most common variant in our patient population is the B117 or UK variant, shown here in green. Unlike the rest of the United States, we still have a large number of the California variant, B1.427.429, which is down from its peak of about 60% prevalence to around 30% now, and that's shown in yellow. And then the rest mix of various other lineages is shown in red, and that has also been stable at around 30% over the last month or so. That includes all the other variants of concern, handful of additional B1617 variants, the double mutant that's currently surging in India, as well as some P1 variants and New York variants and others in that red line. We do have some data to share about the B1617 variant. We provided this variant to colleagues at Emory Mehul Suthar's laboratory, working with the NIAID Vaccine Center to demonstrate the neutralization of this double mutant with various plasma from convalescent individuals shown on the left, individuals that were vaccinated with either the Moderna or the Pfizer vaccines. And what you can see here, and again, this is from a sample that was found at Stanford. And remember, we were one of the first, if not the first, laboratory to report the presence of the double mutant B1617 in the United States. So this is from one of our samples. And you can see that the fold reduction in neutralization here is very consistent across the different plasmas, around 7-fold reduction in neutralization. But what is optimistic here is that all of these plasmas, except for 2 in the convalescent group, were still able to neutralize this virus. So it looks like that the vaccines, though perhaps slightly less efficacious, will still neutralize this variant of concern. That's my report today, and happy to take, as always, any questions in the chat. Thank you.
Thanks, as always, Dr. Pinsky, as well, for those weekly updates, and we're looking forward to more in the future. Next, I want to turn it over for a couple announcements to Dr. Stephanie Harmon, and I'll share a couple slides here.
Thank you, Errol, and good morning. The first event that I wanted to announce and highlight is happening tomorrow, Thursday, May 13th. This is going to be the first in a series of inclusion rounds organized by our Department of Medicine Diversity and Inclusion Council. This is celebrating Asian American and Pacific Islander Heritage Month. So please do join us. We are welcoming Dr. Jennifer Young from our Biomedical Ethics Center in conversation with Dr. Joy Wu, who will be our moderator. And I have placed the registration link in the chat for that event. That'll be a virtual event at noon tomorrow, Thursday. The next event I wanted to highlight is apropos to our grand rounds this morning on a global level. This is the International COVID-19 Conference Lessons Learned, which will be taking place on Friday, May 14th, starting at 7:30. It is co-sponsored by our Center for Asian Health Research and Education, the Center for Digital Health, our Center for Population Health Sciences, and our Center for Innovation in Global Health. That'll be taking place this Friday. Thanks, Errol, and I'll place that registration link also in the chat.
Thanks so much again, Dr. Harmon. And moving on, I want to just do a brief update announcement. You may have seen the email earlier this week that we've been sharing. We'll be hosting a webinar targeted mostly towards healthcare providers in India this evening at 8 p.m. our time, 8:30 a.m. Thursday morning, India time. And I want to really acknowledge Dr. Nidhi Rohatgi, who's really been driving, organizing this. As many of you know, we did a ground round on this recently. Everything in India, the surge continues, and what I understand, I've learned from my colleagues, it's even worse than we read online in many areas. And so thank you so much for all the faculty members, and for those of you who've been helping us share this. We've been really relying on our colleagues to help spread the news to colleagues throughout the world, and we have had a great response. And we have a lot of people who are planning to show and who are already registered for the event. I'll send one more email out later today, and I appreciate everybody continuing to spread the news on that. If there are any questions about it, please do let me know. Upcoming in the next few weeks, we have a number of great topics that we're attacking. We have Dr. Jason Wang, The Art of COVID Command, from school reopenings to controlling nation's borders. The week after that, we will close the National Heritage Asian Pacific Islander Month with a topic on Pacific Islanders, Native Hawaiian Pacific Islander health. And then we'll kick off Pride Month talking about the Pride study with our colleagues. So looking forward to all those topics. But today we have welcoming back Dr. Sarah Lewis Rudman. I'm very happy to have her join us again. Many of you may have seen her speak earlier this year with us back in August. And Dr. Rudman is a clinical assistant professor affiliated with Stanford as part of the infectious disease department, as well as our Department of Medicine. She's the assistant public health controller and the STD HIV controller for the Santa Clary County. She is a Stanford alum, graduated in 2005, heading over to the East Coast in New York, went to Wheeler Corners College and graduated in 2010 at the very top of her class. She then did her fellowship in residency at the Brigham and Women's Hospital in 2013, coming back to the West Coast for a UCSF fellowship in ID, also finishing a Master's of Public Health at Berkeley. She, as I mentioned, is the Assistant Public Health Officer, but she's also the Medical Director for the Crane Center and the London Sexually Transmitted Infectious Disease Clinic in San Jose, and the Co-Medical Director for California Prevention Center in Oakland. She's done and part of a number of different research projects throughout Santa Clara County, many of which I don't have time to go into, but as I'll just personally say that she's been someone I relied on as well throughout this past year. She no doubt has been extraordinarily busy in her typical role in the community, in the county, but of course in the pandemic as well. And I'm personally very appreciative to have been able to have been in contact with Dr. Rudman throughout this pandemic, who's been helping us stay updated, particularly regarding what's going on in our county. She's here to present an update on the response in our county. And Dr. Rudman, thank you so much for being with us today. I will stop sharing my slides so you can pull yours up. And again, thank you for being with us today.
Well, thank you so much for the opportunity to be here again at an alma mater and a group I really feel fortunate to get to work with in my role in the county. And as you mentioned, my usual role is in STD and HIV prevention. And so you'll find at the end, I won't be able to hold myself back from touching on some of the impacts of the COVID pandemic in the STD world. But my goal today will be to really focus on what we're seeing here locally in Santa Clara County, where Stanford is located. And so I recognize we have a broader national and international audience for this talk that hopefully will be able to take pieces of seeing our local microcosm home to wherever they are and thinking about how, as providers, their relationship with the public health department may benefit from these collaborations we're forming here between Stanford in its academic role and its provider role with the public health department. But my hope for the folks watching this live are that you'll understand a bit of where we stand locally in our COVID epidemic and really focus on what resources we can offer you to help with the ongoing vaccine effort and COVID pandemic control, and a particular action that you might be able to take in your academic or provider role that I can help support you in. So while I'll spend a fair amount of time sharing where we are locally, what we're doing locally, and a bit about what we're finding that COVID may be impacting on other topics of public health interest, I really hope we leave time for discussion. I hope I leave time for discussion to hear what you need to support your patient populations, or what you think your patients need directly from us, and what you think we'll need for the non-COVID health recovery effort that we're all facing. So to tell you where we are locally, excuse me. So we, like most of the country, experienced a massive surge in the winter months. And I looked back at the talk I gave in July and August last year, where we were looking at that upswing in July thinking, oh no, this is so much worse than we saw in March. How can we face this uptick that we're seeing? Although fortunately that time we didn't see the level of deaths or hospitalizations that we had seen back in the initial early March surge. And like the rest of the country and like fortunately the rest of California, we are now reaping the benefits of our vaccine effort. And so despite opening up of our shelter in place and risk reduction requirements, we are still seeing decreasing levels of cases across the county. And that little downturn you see at the very bottom right of this slide has continued over the past week in a way that is really benefiting all populations. Unlike the rest of the country, we were among the very earliest hit here in Santa Clara County, which I think was in part at that time due to our international population, our racial and ethnic diversity, our immigrant diversity, and the fact that we serve as an international travel hub. But one of the things that was so striking about our early epidemic here locally was how quickly, I think by the third or fourth case, we transitioned from seeing populations affected by travel, either directly traveling themselves or associated with communities and ethnicities who had associated outbreaks in their home countries, to the exact populations, and mostly populations of color, who are already hardest hit by every other marker of health. And every other social determinant of health, those same populations being hit here almost immediately. And we're now potentially seeing that same pattern with what Dr. Pinsky was describing in that new variants are coming in via travel and initially hitting populations who are more likely to travel or associated with communities who travel, but very quickly transitioning into those non-necessarily travel-associated communities who are otherwise impacted by decreased access to testing, care, dense housing, et cetera, all of those factors that we know have contributed to who's been harder hit by the pandemic. Now, fortunately, the improvement we're seeing right now is benefiting all races and ethnicities, all areas of the county. We are starting to see some of the racial and ethnic disparities improve, but I'll tell you in a moment about why I think that's been the case and how much effort it has taken to make sure that that's happening. Fortunately, we're also seeing our deaths decline, although I'm somewhat struck by how more slowly the death and hospitalization data, our numbers are declining compared to our overall case rates. Now, while our death numbers dropped off faster than our overall case numbers, I think because of the concerted effort to target the highest risk populations for deaths, those living in congregate care settings, and then those over 65 with vaccine first, we did see our death numbers drop off faster than our overall case numbers. But we're seeing this very long tail of both the overall hospitalization and the overall death numbers, and still waiting to see the full benefits of our vaccine efforts really lead to not seeing COVID deaths in our community. And so all of that overall case decline means that according to the California blueprint that dictates what activities are allowed in various counties, mean that we are currently in the orange tier. But my guess is with the trends we've been seeing, we should be headed into the yellow tier very soon. And we are starting to see that in some of our Bay Area neighbors as well. And I think the reason for this is our vaccination effort. And I'm very proud to be part of a county that has just really flexed every resource available, collaborated with provider partners like Stanford University to make sure that we are getting vaccine out as fast as we have it. Now, we did have a little bit of a decrease in our supply at one point in the rollout that really did slow us down and taught us some interesting lessons about the diversity of our socioeconomic status within zip codes in the county. And that while we have very many census tracts that represent lower socioeconomic status and higher social vulnerability, we have such socioeconomic diversity in our zip codes that we don't have very many zip codes, if any, that really recommend that low or really match that lowest tier of social vulnerability. And that affected our initial statewide distribution of COVID vaccine, but a federal influx has meant that we now have sufficient supply to meet the need of every single eligible resident in the county. And so since this slide was published, we're now above 75% of residents 16 and older with at least one dose of vaccine, and above 50% who've completed their vaccination rate. And with concerted effort, we are seeing that the younger ages who became eligible more recently are rapidly catching up with the older age groups, and that the races and ethnicities that were lagging behind somewhat in their initial uptake of vaccination are also catching up. I want to make sure that everyone here in their provider or academic role knows that while we do have gaps across racial and ethnicity lines that we need to continue to focus on to make sure that the vaccine rollout is done equitably, we also have a gender gap that I think is quite interesting. Now, while our data on gender identity are limited, reflected here with the proxy of sex assigned at birth, we find that males are much more likely to be unvaccinated than females across every age group, except for the oldest age group where we have more females than males living. And so this is something we also want to think about. Why is it that males are less likely to be vaccinated, and what can we do to overcome either the hesitancy or the logistic barriers to making sure that that vaccination happens for males as well? So here's what we've been doing in Santa Clara County to try to overcome all of the barriers that are hitting the same communities who've been hardest hit by the pandemic to begin with from accessing vaccination. So first, we have a specific mobile and place-based vaccine strategy, in addition to our large throughput mass vaccine locations that target all of the populations we are most worried about based on their vulnerability of death from COVID, or their vulnerability based on all social determinants of health and how it may impact their willingness or ability to access vaccines. So we have a targeted strategy that focuses on skilled nursing facilities and long-term care facility residents. And at this point, we've been able to visit every single facility that wasn't already completely served by the federal outreach system, and the vast majority of those who wouldn't have qualified for that federal system. We also have a program that specifically serves disabled individuals or people who are homebound with our in-home program that's vaccinated over 750 individuals at this point. And then we also have a program targeting low-income senior housing. Again, the confluence of that social vulnerability with that medical vulnerability, and are making our way through as many of those facilities as we can, having reached 10% so far. We also have a place-based and a work-based strategy to help bring vaccine to the communities who need it the most. In terms of the place-based, we're looking at zip codes and census tracts where we know that the most vulnerable residents reside, and really trying to partner with trusted organizations in those communities, such as schools and churches and large apartment complexes, to make vaccination as easy as possible. We've also used our connections with workplaces formed over the last year of helping to support them in controlling any spread in the workplace and understanding the risk reduction frameworks that have been imposed on their workplaces, using those relationships to help bring vaccine to those workplaces, looking at places that either employ large numbers of individuals who may overlap with some of those vulnerability axes, or places where we know that there have been large outbreaks and are really worried that they could recur, helping to bring vaccines to those locations. We're also doing a strategy, doing a deep dive into specific census tracts who appear to be under-vaccinated compared to their neighbors. And I think some of this has evolved from that lesson learned that we actually have great diversity across zip codes, but when you look deep into the census tract, you may find that there are certain neighborhoods or certain small communities that are being underserved or have unique barriers to vaccination. And so this map highlights some of the variability in vaccine uptake across our county, but that even within that inset community that has a fair amount of uptake, there may be little pockets with much less vaccine uptake, and bringing vaccine in a mobile team to that area can help overcome that deficit. But this is where I think the effort has really needed to focus in terms of overcoming the racial and ethnic barriers to vaccination, to the incredibly rational provider mistrust that we may be more likely to see in communities of color. We have done not only multiple targeted efforts to bring vaccination to communities who need it, but to reach out and provide the information to those communities. And so when you look across the county who's been vaccinated by race and ethnicity, you find fairly similar numbers across all race and ethnicity groups. When it comes to who we're making phone calls to, who we're making door-to-door visits to, we are making sure that we are doing so in the communities that have been hardest hit. Now you'll see here that the number of Black or African American households and individuals we're reaching out to is much smaller than our Asian and Latinx members. Some of that is because of the relative size of the Black or African American community in our county, but some of it may reflect additional needed effort to support Black and African American community members. So in addition to these deep dives into our lowest vaccinated census tracts, we've recognized a need to focus on youth. And this week, we know that that need is going to only grow. And so have had focused efforts for 16 to 18-year-olds at some of our high schools, as well as our large throughput vaccine center at Levi Stadium. Additional efforts to reach males, as we talked about, using targeted advertising and communications, as well as sort of sports related, as we found from some focus groups was going to be potentially successful. Planned expansion of our worksite-based work, launch of more evening and expanded hours, and making sure that we're really completely up and running on weekends so that we are available at the times when people are able to access our services. And then increasing our amount of outreach workers trained to respond to some of the misinformation out there. Just to touch on some of the non-vaccine efforts we continue. Contact tracing, which has been the heart of my role through most of the pandemic, is something we continue to need and rely heavily on volunteer and county disaster service workers who've been redirected to this work. But we've changed the way we do this work so that vaccine scheduling and support and information are integrated into all aspects of contact tracing, so that everybody who's been exposed knows that they are definitely at risk and need to get vaccinated as soon as possible. And everyone who's been a case understands that they absolutely still need to be vaccinated, that they do not need to wait 90 days, as was originally a consideration by CDC when there was a very stark vaccine shortage. But now that we have sufficient supply, we absolutely need to get folks vaccinated as soon as they're out of isolation after having been a case. We continue quality improvement efforts to help make sure that our data collection is robust and increases our ability to query it later. We've utilized a reserve system to help make sure that we can respond to any future surges, as I know we've seen some predictions that we may have another one coming before we really see a substantial drop-off. We've had some amazing collaborations with Stanford University to help improve our contact tracing efforts. One that's been really exciting has been a collaboration with a group that built an algorithm to predict language need for our contacts and cases that we're calling. Most of the time we get a report of a case or a contact, we don't know their native language. And so while we have a fairly high amount of bilingual contact tracers, they may be assigned to English-speaking cases, and the Spanish-speaking cases may be assigned to our English speakers. And so this algorithm has helped us predict the need in a way that we can better match to our staffing and dramatically decreased our translator time. And in addition, we've also had a wonderful collaboration with a number of county partners, but Stanford in particular, as you've opened up your monoclonal antibody therapy to folks who are not already impaneled with Stanford providers. And so we've been able to, every time we identify an eligible case, help to get them to monoclonal antibody therapy, as well as do things like overcome transportation barriers to get to that therapy. We also continue to have robust isolation and quarantine support services available. And so something important for you to know in case you need to refer your cases, your patients to it if they are cases or contacts. We continue to offer financial assistance, in-home support, and motels for folks who need to separate from others for isolation or quarantine. And then finally, and I hate bypassing this in a single slide when it is so important to what we're doing here in Santa Clara County. But we now have a system where through collaborations with labs like Dr. Pinsky's, with Fulgent, with our own public health laboratory dramatically expanding its ability to provide whole genome sequencing, we are now able to sequence almost every specimen that is sequenceable, that has a high enough viral load, a low enough CT value to perform sequencing, that is tested positive anywhere in our county. And so with this, we're no longer focusing our efforts on trying to get you to find us the most interesting cases to sequence. And so we can hopefully save that time for you as providers to do everything else you need to do. And instead, we're really trying to just sequence every single specimen we can and make sure that information gets to the state and to the CDC and get back to you as providers and infection preventionists and infectious disease experts to know what's happening here in our county. And so the link here, and I'll share that again at the end, is to the county's local variant dashboard that highlights the variants of concern and variants of interest that are circulating here in our county that we've been able to identify through whole genome sequencing. And one of the things that I think has been striking again here is similar to what we saw at the very beginning of the pandemic, where a lot of cases were initially associated with travel and then very quickly flexed to community transmission in other communities, especially communities of color, that are not necessarily associated with travel or associated with other countries where we're seeing these variants passed around, but instead those communities of color that are hardest hit by the social determinants of health that impact other negative health outcomes. And so we're seeing that same pattern already emerge here when it comes to new variants, that the initial cases, the first one, maybe the second, are associated with travel. And then almost immediately we're seeing the transmission move from communities who travel or communities who have relatives who travel into communities who may not have any association with travel, but are otherwise impacted by poverty, dense housing, essential service, et cetera. So something to keep an eye on, and thank you for the collaboration with Stanford that's helped make this possible. So here's what I really want to talk about. Here's what we need from you in your provider roles and to think about in your academic roles or other work that you're doing. Encourage COVID-19 vaccination. We did send a provider health advisory to all of you, and the link to the advisory itself is here, but I'll also share a link with how to sign up for our advisories in general. About the changes in Johnson & Johnson, which I won't touch on too much since I'm sure you've heard an earful about TTS recently. How to counsel on activities that are safe for fully vaccinated people. Again, something I'll touch on briefly, but I imagine we've been talking a lot about. And some important information, especially for pediatricians, on catching up on vaccination against other diseases, which I'll share in a moment that we've seen wane during the pandemic. So just a couple of items around what we ask of you as providers and what information we want to make sure you have as providers. One key misunderstanding may not be the right word, but risk assessment that we find that's happening in patients' heads as we are either offering monoclonal antibody therapy to them or having conversations with vaccination about them that has come up, in particular in our collaboration with Stanford, has been that we're finding folks have heard the vaccine message. Getting vaccinated is the most important thing you're doing. And when we tell them, you are sick with COVID and you are eligible for monoclonal antibody therapy, and we think this would be a huge benefit to you. Folks are saying, well, I understand I can't get vaccinated for 90 days afterwards. And so I'm not sure I want to accept this offer of monoclonal antibody therapy because I've heard and have become invested in the idea of getting vaccinated as soon as I can. And it was actually Dr. Ruby Singh who helped speak to some of our contact tracing clinicians and really helped clarify how we can message this to our patients who are eligible for monoclonal antibody therapy, but that therapy itself is so beneficial to them in the context of their disease and offers them very robust protection from reinfection, in addition to their native disease they're experiencing at the time. And so that delay in vaccination is far, far outweighed by the benefits of monoclonal antibody therapy for those who qualify. So helping to message that, I think, is something important for all providers to know. And I also want to touch on this. We're also still hearing patients or providers who are operating under that prior assumption that we didn't have enough vaccine, and so needed to delay those who may have some protection from a prior infection 90 days until they're able to get vaccinated. Now we can vaccinate them as soon as they are done with isolation. The only reason we don't want them to get vaccinated during isolation is to avoid exposure at the vaccine clinics and to make sure any symptoms of their current COVID disease are not conflated with symptoms of the vaccination. But in general, we can get people vaccinated and need to get people vaccinated as soon as they're out of isolation and as soon as their symptoms have resolved. We're also working to combat false clinical information out there that the vaccine is actually harmful for people who have had COVID disease and triggers some sort of recrudescence. While there may be some unusual side effects that do kind of match that, there's no evidence to worry that to make us think that we need to delay vaccination for safety reasons in a way that's different for prior cases than non-cases. We're also seeing some misinformation out there and a lot of concern from people who are pregnant or want to become pregnant or are breastfeeding, that there are increased risks of the vaccine that they need to be particularly concerned about, so much so that they should delay vaccination until they're no longer pregnant or no longer breastfeeding. And so we really want to ask all providers, not just our OBGYN experts, to have that conversation as best they can, starting with all vaccines, and COVID vaccines especially, are incredibly important for people who are pregnant or people who are trying to become pregnant because of the harms of COVID disease in this context. And so that's why we really want to make sure you're starting with that message. And even if there are more nuanced safety conversations that need to happen for a particular patient, that you start them off with the understanding of the huge value, the huge benefit of vaccination in this setting. And then finally, we've heard a couple of concerns of people from both providers and patients that people with HIV on ART or people using ART for PEP or PrEP should not be receiving vaccination until they're paused or something. So I want to make sure that folks are aware that there's not any findings of any ART interactions with vaccination that would recommend a delay in vaccination. And we keep finding over and over again in surveys and focus groups, locally, nationally, internationally, that for those folks who have not yet gotten vaccinated, despite, especially here locally, the widespread access to vaccine, that the one thing they want is to talk to their doctor. We find that people think something about their health experience is unique, and that very rationally, I think it will be beneficial to have a conversation with a provider who understands not only general information about the vaccine, but about their health conditions and experiences and potential risk factors to help counsel them individually. So that's why my plea to you is to think about how can you, in whatever your role, if you provide direct patient care in any field, or if you have other interactions with patients or at-risk populations in an academic role, a teaching role, anything, that you think about how you can use that relationship to help people gain the vaccine confidence they need to choose to get vaccinated. You can also be proactive about this by looking up patients' vaccination status in CARE2, the state's vaccine database, and proactively reaching out to anyone who's unvaccinated to help encourage them, or put information from CARE2 into their patient records so that other providers have access to it. So we have some toolkits available for you, and I think at the end I'll have some resources that I think are really helpful in how to have these motivational interviewing conversations with clients about their particular vaccine concerns, acknowledging their understanding of themselves as unique and having had a particular health experience up to this point, and how they may see relationships between whatever health experiences they've had, whatever comorbidities they may have, and the benefits and risks of vaccines to them, and ask them to share what are their particular concerns so that you can help address what it is they're concerned about and not spend too much time on things that they don't particularly feel concerned about. Asking permission to share information with them, hoping to change their perspective and hoping to personalize it as much as possible. Now, you may encounter folks who still decline, and I find it helpful to let them know that you're going to offer it again. We know from a large array of data that many patients who decline at first will accept vaccination later, especially when it comes to parents making decisions for pediatric vaccinations for their children. Offering reading material for folks to go home and digest outside of the immediate decision-making. Confrontation isn't really the right word, but folks may reflexively say no in a moment when they have to decide, and later on reconsider in a different way. And then don't over-remember this. Don't think that because you've had one no from a patient, your next patient's going to say no, and so start that next conversation fresh and know that you're doing the best you can. And then with this week, we know that the Pfizer vaccine has now been FDA authorized for 12 to 15-year-olds. And so in addition to statewide and CDC resources for pediatric providers to help with that conversation about consent and particular risks and benefits for pediatric populations, we here in the county expect to be able to offer Pfizer vaccine at all of our locations, all of our mass vaccine locations, and most of our community-based locations, ideally tomorrow, but almost definitely by Friday, after the ACIP meeting today offers their recommendations and the Western States Scientific Coalition offers any of their additional feedback as well. We do have other resources for you on our county websites, some that we've developed locally about the Johnson & Johnson safety concerns to help have that more nuanced conversation, and want to make sure that those of you who are local providers have the information, oh, I apologize, I realize it says TSS instead of TTS, about how to report both into the VAERS, the federal system for reporting vaccine adverse events, and how to report to us locally in the public health department if you think you've got a patient who received a Johnson & Johnson or Janssen vaccine and then developed TTS afterwards. I will touch only briefly on the CDPH guidance for fully vaccinated people, mostly to say that we here in Santa Clara County align with the CDC and CDPH guidance, which more or less says that we can allow certain activities with lower level of protection for fully vaccinated people, defines who's fully vaccinated as those who are 14 days after the last shot in whatever series they're receiving, whether that's a 2-shot series like any of our mRNA vaccines or a 1-shot like the Johnson & Johnson vaccine. Now, for those of you who have time to read this cartoon, this is what every day, all day is like for me and probably for many of you. Can I X after I'm fully vaccinated? What about this circumstance? What about that circumstance? So I will do my best to field any questions about these. And I appreciate there are a couple of particular frustrations around the fact that not all of our regulations have yet caught up with this most recent guidance. So please know that we intend to catch up with them here in Santa Clara County. And my understanding is the state does as well, both in terms of any CDPH harm reduction regulations, as well as Cal OSHA, which I know is working on their next round of regulations, because the current ones still require some elements of masking, testing, work exclusion for fully vaccinated people that the CDC no longer recommends. 2 other questions I get frequently are, what about folks who've been fully vaccinated by a vaccine that is not authorized by the FDA? And we categorize those folks into basically 3 categories. Those who only got partially vaccinated with a non-FDA vaccine, in which case we recommend they restart vaccination with an FDA authorized vaccine. Those who are fully vaccinated, but with a vaccine that is not on the World Health Organization's approved list. Those folks, we would not apply the fully vaccinated person recommendations to them, and would recommend they also be fully revaccinated with an FDA authorized vaccine. Then there are those who have been fully vaccinated by a vaccine that, while not approved by the FDA, is on the World Health Organization's list. And that's really 2 vaccines by AstraZeneca. If somebody has completed the full course of those, we do not think they need to be revaccinated with an FDA authorized vaccine. And we do think they can be treated as other fully vaccinated persons with respect to all the CDC vaccines. And then one last topic that was touched on during the initial briefing is that currently the policy in Santa Clara County and in CDPH, according to their guidelines, is that fully vaccinated people who test positive with a molecular assay should still isolate according to usual recommendations. There are a lot of nuances here. If of interest to the group, we can get into some of them, but I think that is the basic assumption we should all start with, because there's still so much we don't know about how contagious fully vaccinated people may turn out to be when they do acquire COVID infection. My last portion I'll share with you, and then we'll leave the rest of the time for questions, will be about some of the changes we've seen in non-COVID outcomes during the pandemic, just to think about what the recovery period is going to look like, what the work will be cut out for all of us, especially us at the public health department, after we really get COVID control. Although, of course, this work can't wait until we're not seeing COVID cases anymore. It needs to start now. So we've seen a trend over the last year of decreased prenatal care and delayed initiation of prenatal care. We've seen a decrease in usual childhood immunization, although there's already been some catch up during the winter of last year. But part of why our recent health advisory asked you to help make sure that clients are also caught up on non-COVID vaccination, as well as make sure that they're COVID vaccinated. we've seen some trends that were starting long before the pandemic and have continued throughout it. One particularly concerning has been a slow increase over the past several years in suicide deaths. And this has continued, although we actually had a slight decline in visits to the emergency department for suicidal ideation and suicide attempt. The actual overall number of deaths continues to slowly increase, not clearly impacted either for good or bad by the pandemic, but something we'll have to return to facing as soon as we have the bandwidth to do so. While interestingly, we've seen a little bit of a decline in ED visits for other drug overdoses, we've continued to see the slow rise in opioid overdoses and perhaps even a further uptick in opioid overdoses in the past year. And because part of my role as STD and HIV controller is to administer our county's needle exchange program and syringe access program that also distributes naloxone to its clients, we are finding very, very high need and utilization and reversal of overdoses in our naloxone distribution program. I believe on the order of about 250 uses of naloxone for opioid overdose just in the past year. And then I can't help but share the STD data with you. And if you had a momentary spark of joy at seeing this drop off in our chlamydia data, I'm about to dampen your enthusiasm. It is possible that the dramatic decrease in chlamydia cases we saw in 2020 is due to real changes in sexual behavior, risk factors, sexual network factors, and there really was less transmission of chlamydia. But because so much of chlamydia is diagnosed by routine screening in asymptomatic individuals, my worry is that this drop-off actually represents a dramatic decrease in testing and diagnosis, and we may have a huge amount of catch-up to do. We saw a similar decrease in gonorrhea, although we did see what we think was a true decrease in 2018 that bounced back up in 2019. We have had a decades-long trend of increasing rates of gonorrhea, especially affecting men who have sex with men. And I worry again that the decrease seen last year is more related to decreased diagnosis and routine screening in the past year than due to real decreases in underlying disease. Part of the reason I'm concerned about that is that we have seen an increase in disseminated gonorrhea infection. The gonorrhea infection that travels to the bloodstream and causes meningitis and endocarditis and most often septic arthritis or polyarthritis syndrome, and therefore is much more likely to land someone in the hospital and lead to a diagnosis. These numbers have increased. The actual numbers are too small for me to share in detail now, but I can tell you on a statewide level, we've seen increases. So while we both want you to be on the lookout for disseminated gonorrhea cases and have a high degree of suspicion for them, it seems to be showing me that the tip of the iceberg is bigger, and therefore I think the entire iceberg is bigger, even if we're not seeing it with our drop-off in gonorrhea screening. We saw only a small drop-off in syphilis cases, but unfortunately saw the exact same number of congenital syphilis cases in 2020. And this is one of the real emergencies in our county. This is an entirely preventable, tragic outcome, completely treatable with antibiotics during pregnancy when diagnosed early, and potentially leading to stillbirths or even neonatal death or lifelong disability when not treated. And so while, again, there may have been a true decrease in the amount of syphilis in our community, I think that's less likely than there was a decrease in screening, because we are seeing these stable rates of that most likely to be diagnosed outcome in these infants who are born to parents who were diagnosed with syphilis during pregnancy. And then finally, again, I would like to think, and maybe it is true, that the decrease we saw in HIV new diagnoses in the last year was due to a true decrease in HIV transmission. We won't really know for some time until we have the findings of how many of these were late diagnoses, how many people can convert to an AIDS diagnosis within the year following. But again, my concern is that we saw a drop-off in diagnosis. So with this decrease in prenatal care, some initial decline in childhood vaccination, an ongoing worsening trend of suicide deaths and opioid use, and STI trends that I think really worry me for a drop-off in diagnosis despite stable or maybe increasing underlying disease. We really have our work cut out for us in the next year. And all of this is added to the economic crisis that our patients are going to be experiencing, the mass evictions we may be seeing, and changes in our housing crisis. So any questions, comments, ideas, collaborations around how we're going to do this work of healing our community and setting ourselves up to be a stronger health department, a stronger set of healthcare providers, a stronger academic institution, to make sure that we can respond to the backsliding that may have happened in certain health progress made in prior years, or set ourselves up to not experience a pandemic like we have, and to really retain the lessons learned of the last year and a half. I would love to hear from all of you. So that's what I have to share, and I'll make sure these slides are available because there are some supplemental slides with additional data I mentioned verbally. But I think I want all of you to know that I think the vaccine effort is working, and I think we see that from the way that our rates may remain low despite dramatic reopening of activities we haven't been able to do for a year. We are potentially seeing recurrence of this pattern of travel-related illness spreading to vulnerable populations, repeated with some of the incoming variants, which for me drives a dual interest in both paying attention to travel patterns and travel cases, but also never forgetting that you may see these variants of concern quickly arising in all of our vulnerable populations, that we really need your help when it comes to instilling vaccine confidence in the folks who've not yet been vaccinated, and that we've got a lot of work cut out for us when it comes to the rest of the health recovery. And so I'll leave this last slide up with some of our resources, where to access all of the data that we try to make available to you, both in digested, visualized form on these dashboards and available for download for your own manipulation and understanding. Some public-facing information on how to access information about vaccines, as well as scheduling vaccine appointments. Some of those provider communications and more detailed resources around vaccine confidence, all of our information on isolation and quarantine, including the latest interpretation of those CDC guidance for fully vaccinated persons, and then our overall provider website, where you can do things like sign up to receive our health alerts directly or submit electronically case report forms or death report forms. Thank you, and I'll pause there and see what questions we have.
Dr. Rudman, thank you so much for that excellent overview of all the aspects of things that are going on in our county. I'm going to get right into questions as we have a bunch that are growing as we speak. The top question comes from Dr. Michelle Berry, an important one. She asks, as vaccine passports are being considered to go to work, travel, go to school, what efforts are going into easy electronic recall of multi-centered vaccine administration as cards are lost or forfeited? Can there be one electronic contact to enter vaccine history?
Thank you for going straight to the heart of what we are spending a huge amount of our time on here in the local public health department, but are really leaning on a statewide collaboration, because just as you touched on, a vaccine passport is not meaningful if it only carries data from people who are vaccinated by Santa Clara County. Our borders are completely meaningless when it comes to how COVID travels, how people travel to work, to get vaccinated, to get health care. And so a system won't be meaningful until it is including national data of vaccines, or at the very least statewide data of vaccine history, is easily accessible. And I think the piece we're struggling the most with is equitable, because the same technological solutions that would make it easy for folks who do have a smartphone and a smartphone plan and high degree of technological and medical literacy to be able to quickly access their own vaccine history and share it for all kinds of settings. Those are those same systems that are going to be most difficult for the populations who struggled the most with COVID and who struggled the most with getting vaccinated. And so we're really worried about setting up a system that creates differential access to various parts of society, whether that's shopping or an event or a workplace, based on people's poverty or medical literacy. So it's a nut we haven't cracked yet, but one we're putting a lot of effort into and really trying to push for a statewide, if not a national solution.
Dr. Kaki asks, is it appropriate to be vaccinating children? The risk is low, and these could be potentially used internationally as well. Any thoughts on the distribution of these vaccines?
I'm of two minds here. I absolutely hear you that it is an imperative for the United States to participate in the national control of COVID, the international control of COVID, the international access to vaccination. And as we are experiencing here from the very beginning of the pandemic to what we're seeing with the variants we're tracking here and that Dr. Pinsky's lab has been so helpful in elucidating, that same pattern of understanding what a global community we are and how that hits us here at home is very apparent. So until we contribute to the control of COVID internationally, we won't be able to control COVID at home. So at the same time, we do know that the ability to get American and Californian and Santa Clara County youth back to school has massive impacts on not only those individuals' education and safety and nutrition, but massive impacts on poverty and equity in our community, because the same families that are impacted by COVID are impacted by lower access to vaccines, are more impacted by having their children home from school. So I see that we need both. And fortunately, right now, we are in a situation where we have the vaccine supply to offer it to our 12 to 15-year-olds. And so we're going to go ahead and do that and do it quickly and do it safely, because we know that there will be benefit that disproportionately benefits those who need it the most. But at the same time, I can't diminish the importance of making sure we get support the vaccine effort internationally. And I'm really relying on my federal partners to make sure that that happens and happens quickly and happens well.
Dr. Ash asked another great question. What policies should we be advocating to ensure that public health capacity does not degrade as the pandemic passes?
I really appreciate that question. And this is one of those moments where I'm really proud to work in Santa Clara County. We are fortunately at a moment where, at least right now, we are seeing federal investment, state investment, and a strong local investment in trying to retain what we've built in the public health world. And so just this past week, for example, a large influx of federal grant funds that are flowing through the state to us here in Santa Clara County are going to be utilized to build what we hope to be a permanent expansion of the public health department. And this is very unusual, especially for those of you in the academic world who live grant to grant, thinking about funding or creating something that will live past an initial funding influx. We are creating expansion of not only our ability to investigate outbreaks and diseases of new interest, but our ability to perform the kinds of whole genome sequencing and digest it and act on it. And then the huge data infrastructure that we've built and then relied on throughout the entire pandemic has really been cobbled together, has relied heavily on partnerships with academia, and is something we can't let go of. And so we are also building a huge amount of infrastructure that, again, is intended to be permanent, that will expand our ability to create automated data flows, digest that, act on it, perform research based on it, build the academic partnerships and collaborations we need to sustain it. And so I'm actually very hopeful that we are seeing that here locally. Now, what you can do to help make sure we stay that way, I think, very much varies depending on your role, but voicing that support in whatever you think is fitting of your particular role in your provider academic world, voicing it locally if there are contested issues about what resources are going where, voicing it nationally, voicing it internationally if that's your role, I think is going to be incredibly important. And then thinking about what any academic and provider collaborations with the public health department should look like, thinking about not only building public health infrastructure in the public health department, but building public health infrastructure in your own institution and having conversations with us about what that would look like, I think will also be incredibly valuable.
We have Dr. Harrington who'd like to ask you a question as well.
So first off, Dr. Rudman, thanks again for joining us. This has been a terrific presentation and your leadership throughout the pandemic has been extraordinary, so thank you. My question is going to turn a little bit away from infectious disease, which has obviously been the focus, to the chronic diseases, which certainly have been additionally uncovered there, the implications of untreated hypertension, diabetes, cancer, et cetera. What do you see the change in infrastructure for Santa Clara County helping or aiding in the battle against the chronic diseases, most notably heart disease and cancer?
Excellent question. And I think maybe we should try to get some of my colleagues back who really live in this world from the public health perspective. What I've seen have been that building the data infrastructure, both in terms of how we're going to gather information from electronic health records or provider partners or other community resources, and the ability to digest that are hopefully really going to inform our public health efforts. So we understand what populations are being affected in what way, by some of the lapses in preventive care that we've experienced over the last year, or in treatment we've experienced over the last year, and can understand and then study what public health efforts are really most meaningful in reversing that backsliding that we experienced. But again, I'd be really open to hearing from anyone, and we'll make sure my information is shared with everyone afterwards, what kinds of collaborations can be helpful. And I didn't touch on it here, but I do know that there's also additional large amounts of effort to build our we do have a community health or chronic disease and injury prevention group and a healthy communities branch within the public health department that we're hoping to expand internally, but also more importantly, maybe hoping to expand in terms of our relationships with community partners. I think we've learned when it comes to community, to chronic health concerns and to the communities hardest hit by them, that's one more area where we can't underestimate the power of collaborating with community-based organizations. And one other benefit that's come from the last year and a half has been strengthening some of these key collaborations. When we do things like our door-to-door testing or community health promotion, we've done that not ourselves and not in a vacuum, but by relying heavily on community organizations and making sure that the influx of support that came to them during the pandemic doesn't dry up is another major priority for us.
Dr. Rudman, I have a question here from Dr. Kalivas. He asks, when vaccine, and you touched on this a little bit in your slides, he asked, when vaccines become FDA approved, where does the county health department stand on making the carrot/stick incentives for vaccination? Like, you can do this if you get vaccinated and so on. Also enforcing perhaps the military, police, health providers, teachers to have to be vaccinated.
So I'll start with the sticks. So in general, in terms of what is allowed for fully vaccinated persons, we do want to align fully with the CDPH and CDC recommendations. And so right now our intent is not to issue additional restrictions for people who are not yet fully vaccinated, because our best understanding is by aligning with CDPH, by aligning with CDC, we can help make sure that, again, those porous borders allow for people to have an understanding of what they can do from place to place, and to make sure, ideally, that those recommendations are aligned with the best scientific evidence. As for the carrots, I think we've taken a number of tacks in terms of how we try to promote vaccination. Some of them, as straightforward as a free cookie or a boba drink at a vaccine site, just to make sure people have that little added incentive to come and get vaccinated now and make it a priority, and not wait another day, not wait another week. But I think, again, we can't really underestimate the importance of what we may think of as incentives, but what are really reimbursement for the value of somebody's time. And the more somebody may be struggling to get away from work, to get away from childcare, to get away from other responsibilities to make the time to get vaccinated, the more they may benefit from whatever that incentive may be. So I'll tell you, we're looking into and interested in and very open to suggestions about how else we can incentivize people to get vaccinated. And I think the more we understand why people are not getting vaccinated right now, the more we can make sure those incentives are appropriately targeted.
Dr. Rudman, we're just passing 9 o'clock. I think we'll go ahead and close it from here. We have lots of more questions, and perhaps if I can send some via email, if any you would like to answer, we can add that in our follow-up email to everybody and put on our website as well. Thank you again for joining us once again. And we're really looking forward to inviting you again down in the future, perhaps also to focus more on your expertise as well as we one day get past the pandemic. But thank you so much for being with us throughout these tough times. I really appreciate everything you do. And you'll see in the chat, there's multiple comments thanking you for the amazing presentation. I just want to add my thanks as well. I hope everybody has a great day, great rest of the week, and we'll see you next week.